Today I'll be presenting the economic cause of emergency department crowding and its implications for hospital efficiency and public health outcomes. Emergency departments play a critical role in the healthcare system. However, crowding has become a growing problem across the United States. This presentation will explain why ED crowding is not only a clinical issue, but also an important economic problem. I will also share data from New Jersey and discuss policy recommendations. The purpose of this study is to examine emergency department crowding through an economic lens. First, I analyze the scale of the problem using national and state level data. Second, I apply key economic concepts such as marginal cost, negative externality, and opportunity cost. Finally, I discuss emerging trends and provide recommendations for hospital administrators and public health practitioners. Emergency department crowding occurs when the demands for emergency care exceeds available hospital resources. This includes limits in staff, physical space, and inpatient beds. When crowding happens, patients experience long wait time and delay in care. Some patients even leave before being treated. At the same time, doctors and nurses are under extreme pressures. This environment increases the risk of clinical errors and poor outcomes. Emergency department use remain extremely high in the United States. According to the CDC, there are more than 140 million ED visits every year. The average patient waits between 40 to 60 minutes to see a provider. Non-urgent patients often wait 2 to 4 hours or longer. Boarding times for admitted patients frequently exceed 6 to 12 hours. These numbers show that ED crowding is not temporary. It is a persistent national problem. ED crowding directly affects the patient safety. Research has shown that mortality increases by 10 to 30% during crowded conditions. Time-sensitive conditions such as stroke and heart attack are especially affected. Delayed treatment can lead to a worse outcome. Crowding also increases infection risk because patients wait in closed space for long times. These risks show that ED crowding has serious public health consequences. Emergency department crowding is also a serious issue in New Jersey. New Jersey has some of the highest ED utilization rates in the Northeast. Urban areas such as Essex, Hudson, and Camden counties experience especially heavy demand. Many non-urgent patients in New Jersey wait over 4 hours to receive care. Some hospitals also report LWBS rate above the national average. Ongoing nurse shortage and regional hospital closures continue to increase crowding pressure across the state. Marginal cost refers to the cost of treating one additional patient. In a crowded ED, the cost rises very quickly. Hospitals must pay overtime to nurses and physicians. Staff must rush diagnostics and treatments. Equipment and bed space became scarce. As a result, the final patient treated during a crowded shift costs far more than early arrivals. This reflects sharply rising marginal costs. Emergency department crowding creates strong negative externalities. A negative externality occurs when one person's action imposes costs on others. When non-urgent patients use the ED, they delay critical patients. These delays increase the complications and deaths for others. Crowding also raises infection risk across the department. These costs are not included in the patient's bill. Instead, society and the healthcare system absorb them. Opportunity cost represents what is given up when a resource is used for one purpose instead of others. When low-risk patients occupy ED bed, hospitals lose the ability to treat high acuity cases efficiently. Hospitals also lose revenue opportunities. Critical cases and surgical admissions bring higher reimbursements. When EDs remain blocked, hospitals cannot remove these patients into care. This reduces both efficiency and financial stability. Emergency department crowding reflects a several supply and demand imbalance. On the demand side, many patients lack access to primary care. Uninsured patients, medical patients, and mental health patients rely heavily on ED services. On the supply side, hospitals face nurse shortage and physicians burnout. Many community and rural hospitals have also closed. Fewer emergency departments must now receive more patients. Several trends continue to worsen ED crowding. First, the nurse shortage limits how many patients hospital can safely treat. Second, the aging population increases emergency care demand. Third, mental health boarding keeps patients in EDs for days as they wait for placement. Fourth, hospital closures continue to shift demand to our remaining facilities. Technology such as telegraph offers some help, but it cannot replace lost beds or workforce supply. Emergency department crowding reflects a system-wide economic imbalance. It increases operational costs and worsens patient outcomes. It also threatens hospital financial sustainability. Crowding is not caused by a single factor. It results from labor shortage, limited downstream bed capacity, and poor access to primary and mental health care. Several policy actions can reduce ED crowding. States should expand urgent care and primary care access. Hospitals should improve nurse recruitment and retention. Real-time bed coordination systems should reduce boarding delays. Public health agencies should expand price mental health facilities. These steps should improve both safety and efficiency.